But there's always that balance, right? And I think a couple of people here are quality and risk managers. So separating that, the risk management side, the protection of the assets of the organization, from the quality side. But as long as our intent for those QCC reviews are for the purpose of quality improvement, and they're afforded those protections, we seem to have very good uptake on that. And there is an information firewall between those two, so we separate those investigations done by our insurer that may address that litigation piece, as well as the reviews done by our quality of care team. So some of the changes that we made were, and I just got new batteries for this clicker, but it doesn't seem, I think I don't have a very good connection, so bear with me. I'll just use my finger to point. So some of the things we did then was expand the role of our quality of care committee. Instead of just investigating those tip of the iceberg kind of incidents, the critical incidents were very few and far between. In fact, we didn't have any for 2 years. We expanded it to address all incidents that, even though the outcome, the actual consequences were mild harm, moderate harm, or no harm, there's a high probability of more significant consequences. I think I'll be okay, thanks. So with that, it gave us the opportunity to learn a whole lot more. And when we'd look at incidents, they'd say, yeah, there was no harm, but man, we do this procedure like 7 times a day, 5 days a week, and we've never had this fail before, but the opportunity is there. And so we ought to fix this. We put in place a more rigid structure for our quality of care reviews. So we have an oversight by a quality of care committee, for which we have our chief of staff, we have physician representation, a couple of physician leads, business unit leaders, a chief nursing officer, a couple of quality specialists, and a co-chair physician and quality co-chair. And so we have a more formalized system for investigating and analyzing our incidents, for identifying recommendations and ensuring they're rigorous and system focused, and for monitoring those recommendations through implementation to track to make sure they get put in place and they stay in place. And that's been a big part of this QCC review process, is around implementing corrective actions and ensuring they get done, and they don't just drift off and float off till people forget about them. So this allowed us for improved transparency, integrity of our process, that we're using the same tools and processes for these significant incidents. And when the reviews and the recommendations came back to the quality of care committee, there were people there from across the organization that would say, well, this isn't just a problem in the main OR, this affects our cataract surgery, this affects our endoscopy, this affects, and we were able to transfer those lessons learned from that forum and free up resources to address those. And it really helped with the accountability of tracking and closing recommendations and corrective actions. Our directors were now on the hook for those. So that was a really significant shift from our previous state. So now we start to look at not just through this reactive process, but keep in mind that there are all kinds of other proactive activities going on that's helping to improve patient safety and quality of care. So we don't have the Joint Commission, we have Accreditation Canada. So we're trying to proactively identify through that process where our gaps and weaknesses are. We're a best practice spotlight organization. So we are adopting best practices. We have a risk assessment checklist from our insurer that helps us do a risk assessment of our exposure to risk and actions to improve. And the latest one is part of a network of hospitals within our region, is focusing on always events. So the Canadian Patient Safety Institute has provided a list of never events, a little bit different than the Joint Commission, but not that far off. And so from that, we're focusing on always events. What are the things we should always be doing to get the right outcome for things that we know have preventable strategies to reduce the risk of harm? Reactively, though, through our incident management system, through work orders, patient complaints, and this QCC process, we're really trying to do a better job of melting the whole iceberg, not just those most critical incidents. So it's given us a lot of leverage to move that forward. But of course, all of that is in the context of focusing on high reliability. And it's hard to keep your eye on the functioning of the hospital and high reliability at the same time, because we're a long way away from that. But just even having the language of those key elements of high reliability, a strong safety culture, leadership and robust process improvement, which falls in our bailiwick as well for the quality improvement piece, but trying to influence our leadership and steer safety culture, along with the characteristics of high reliability that come through those things like resilience. We'll talk a little bit about what we do to help with resilience of our staff members, deference to expertise within our investigation to get the right people in the room, not necessarily the most senior, but the right people. A reluctance to simplify. We're used to going down to a root cause and one recommendation. Now looking at all of those causal factors, root causes and recommendations. The sensitivity to operations, that we do need to keep going, and we have to figure out ways that we can manage to keep caring for patients, as well as finding better solutions that are more reliable. And then the preoccupation with failure, moving to beyond just the tip of the iceberg, to starting to look at all of these other opportunities. And they don't necessarily all end up just as patient safety incidents. We will investigate. We had a bomb threat, and we had some of our staff very concerned about how we responded to that. So we did a comprehensive review for that, took them through that process to identify gaps and weaknesses.
How does your accrediting body compare to the Joint Commission accrediting body?
I'm not really sure. I think they're not that far off, but I've never compared the standards. We have an accreditation lead, a coordinator, who's a quality specialist, works alongside with me, and that's her role to kind of manage the organization and be at a continual state of readiness for our accreditation. So I could probably let you talk to her, but I'm not.
How often do you guys get inspected?
We were every 3 years. Now it's gone to a 4-year cycle.
Okay. So similar.
So yeah, we're just waiting. 2020 is our next, 2020 is our next survey. So we have developed an integrated quality management framework, which is part of a accreditation standard. How do we handle all the elements of safe, accessible, effective, timely, equitable, and patient-centered care? And so of which our incident management system is a piece. We formalized our patient safety incident management system, provided a toolkit and guidance for how we deal with not just the most critical incidents, but even those no harm or reportable circumstances. And so this was our conceptual model. I don't expect you to be able to read it, but the idea was we've got a well-defined process for dealing with the most critical of our incidents, but there's a lot of other stuff that may need more investigation based on potential for harm, right? The likelihood of harm. So we have a filter that we put things through that include not just the severity, but was this a never event? How complex is the incident? We may do a risk assessment on the likelihood and the consequences of a repeat incident, whether available resources are available or could be needed or used, the potential for learning. You know, sometimes we'll do a comprehensive review and then have another incident very similar. We won't do another full review. We may just look at failed safeguards. And then the different types of analysis that we can do, anything from a comprehensive review, which would often include taproot, to a concise review for those less significant incidents, a multi-incident analysis if we're starting to note an adverse trend, or just trending incidents at the lowest level to help give us some insight. And then it depends on the makeup of the team based on the type of investigation and the amount of harm, the amount of attention it's going to get. And so there's a reporting structure for all of those kinds of incidents. So even though these are no harm incidents, may not have heavy duty review, they are trended and reported at the director level for them to see if there are any adverse trends, at which point they may look at programmatic improvements. The other paradigm shift was from the IHI triple aim on looking at population health, trying to manage and optimize per capita cost while ensuring a positive experience of care for patients, one of the gaps and one of the things that's noted is burnout for staff and caregivers. And so there's talk of, and I'm not sure IHI is committed to it, but I heard Don Berwick talk about it, and we certainly are, around ensuring the experience for the care provider. The rate of burnout can be as high as 50% in some studies. And certainly if there's an incident involved, we see that rate of burnout much higher. And we have great healthcare providers, and it's a shame to lose our healthcare providers because they can't manage. There's the resilience there for coming back from one of these significant incidents is really a tough thing to find. So we use our snap chart to help us understand incidents. We make sure we reinforce that we're focusing on systems and processes, not on individual performance. We create a collaborative, open, and professional environment for this. And I'll be perfectly honest, when we put these timelines together and have people contribute to those timelines in team settings, either individual or team, and bring the team back together to see the extent of the incident, they're always surprised. They're always surprised at how many things had to go wrong to get to harm for our patients. They're also very surprised that there were other things besides the thing that they touched, their part of the care, that led to this incident. It's very challenging collecting all that information from the different documentation systems and pulling it all together. So that's where I really love the snap chart, because we can go through, the nursing assessment and the physician notes and DI reports and lab reports and pull it all together in a single place. So it makes it much easier for people to see the sequence of events and the outcomes.